Thank you, Ray, and I'd like to thank Dr. DeVries for inviting me to give a talk at this conference. It's a stellar group of speakers, and I'm excited to hear the other speakers later on. So this is where I work. This is a small community hospital in rural upstate New York. You're looking at the hospital's $45 million addition that was completed recently. And those of you from the southern part of the country may think that we're building and adding to our hospitals because the population's growing, but in fact, the population in our neck of the woods has probably dropped by 1 million or more over the past couple decades. Hospitals are building to compete with each other for the remaining patients, so that $45 million addition is pretty impressive. But I also work here. And this is a pretty standard representation of migrant farmer housing. And what this talk is really about is how to get the patients here, healthcare in this place. And that's what we're going to talk about. First, let me tell you a little bit about how I began this journey. 10 years ago, an Hispanic man was brought into my office with an interpreter. He had been pruning grapevines in the winter, and he had frostbitten fingers. As the weather had not yet been terribly cold, I asked him if he was wearing gloves. No, he was not. He had no gloves. Shortly thereafter, I met with Pat Rios, who in 1989 had the vision to establish Finger Lakes Migrant Health. And the following spring, I began a surgical clinic at their primary care site, which is called La Clinica. At the outset, I should start with certain disclaimers and definitions. As to the disclaimer, you are listening to a general surgeon. I am not an academic, I'm not an economist, I'm not a sociologist, and I'm not an expert on migrant worker studies. Everything you're going to hear me talk about is lessons I have learned from working at the clinic for the last 8 years. As to definitions, the term migrant worker is pretty intuitive. One who crosses state lines at least once every 2 years in search of agricultural employment. Upstate New York is grape and apple country. Currently, many of the migrant workers who harvest these crops are Haitian. They typically start each year in Florida and migrate north with the crops, ending in New York or New England in the fall. They leave for Florida and then to Haiti shortly after the last apple is picked. The term seasonal farm worker is not so intuitive, and it's a fairly recent definition. One whose primary source of income is from agriculture, but who no longer migrates and lives in the region year-round. In rural New York, seasonal farm workers generally work in the dairy industry. Based on my limited experience, almost every dairy farm in New York State, outside of Mennonite farms, hires one or more seasonal farm workers. And agriculture, especially dairy industry, is a huge business in New York. According to a dairy farmer friend in Vermont, that state has also had a recent and dramatic shift to seasonal farm workers, with currently more than 50% of workers on dairy farms there being Hispanic. Nationwide, it's estimated that there are anywhere from 3 to 5 million migrant and seasonal farm workers, and this number is clearly increasing, and I think that estimate's probably low to start with. The demographic profile of this population is young and male. There are exceptions, of course. I've treated several workers in their 60s, my favorite being a childhood friend of none other than Elvis Presley. And there's one nuance that is worth mentioning. The majority of foreign farm workers that I encounter come to work in this country for a limited period of time, 4 to 5 years, before returning to their country of birth. At least in our area, these workers come not as immigrants, but as temporary workers intent on earning money. Where they wish to be is home, and right now that would be generally Mexico. The history of migrant farm work, of course, is relatively brief. Prior to 1864, large-scale farm work was done by slave labor. Waves of migrants, both native and foreign, have filled that role ever since. The history of organized farm care for this group is even briefer. Those of my generation may recall that on the day after Thanksgiving, 1960, Edward R. Murrow's Harvest of Shame brought the stark working conditions of farm labor into America's living rooms. Even today, this broadcast, which of course is available on YouTube, is a powerful reminder of the harsh conditions facing those who harvest our crops. 2 years after Murrow's expose, the Migrant Health Act was signed into law. This act led to the establishment of approximately 400 federally funded primary care health centers. It's estimated that these centers provide care to only about 15% of the migrant and seasonal farm workers. And I did talk to the local clinic in this area, and they do have one of their clinics is devoted entirely to migrant workers. Surgical conditions in this group are as one would expect. Hernias are common and often long-standing. Anorectal complaints are fairly frequent, probably due to a change in diet. Of special interest is a high prevalence of vague abdominal pain. This group is under a huge amount of stress, and they readily admit to high levels of anxiety. Issues include fear of job loss, concern for family back home, and fear of deportation. Although I do a variety of office surgery at La Clinica, the real difficulties in obtaining surgical care for this group is hospital care. And that is what I wish to discuss today. Agricultural workers are exempt from the wage and hour standards that the average American takes for granted. Sub-poverty wages and lack of benefits in this group create barriers to obtaining health care and specifically surgical care. These economic barriers, significant in themselves, are magnified by other circumstances to make it almost impossible to obtain surgical services in all but emergency situations. We work in a healthcare system that is dominated by insurance agreements. In upstate New York, most hospital and professional fees are determined by agreements with insurers, whether the commercial, Medicare, or state-based safety net programs. Without these agreements, usual and customary fees prevail, fees which are substantially higher than the negotiated rates available to the insured. Discounts below Medicare that are individual and arbitrary can put practitioners at the risk of charges of fraud and abuse from the Office of Inspector General. Hospitals present different hurdles. Costs of surgical procedures are determined post facto and can easily exceed the proposed cost by 50% or more. Every antibiotic, mesh, and minute used increases the final cost of a procedure. Yet almost no employer provides health care to farm workers. Although these workers' incomes would easily qualify them for safety net products, most are not eligible. If they are eligible in one state, these programs cannot cross state lines with them. In addition, county-based safety net enrollment processes are difficult for many migrants to complete. Language, educational level, and transportation all add up to prevent any significant enrollment. The result is that migrant and seasonal farm workers pay cash for medical care. Agricultural workers are the classic piecework employee. Since many days of work are lost due to inclement weather, poor crops, or illness, even scheduling a surgical consultation will cost the patient wages he cannot afford to lose. Patients may skip scheduled appointments due to a sudden lack of transportation, or because that day was the only good day for picking apples that week. For more recent hires, time off work for surgery presents a very real fear of losing a job. If the surgery is due to a work-related condition, such as a hernia, and farm workers are covered by workers' comp laws, most workers will not report this for fear, often quite justified, of job loss. Transportation to and from a consultant's office is rarely within the reach of this population unless they are supported by a federally funded clinic such as ours. At least in our neck of the woods, the activity of Immigration and Customs Enforcement officers, known as ICE, has created an environment of fear among all migrant workers, even those with proper documentation. As a simple example, a fully documented U.S. citizen that works at our clinic failed to return from work one day after she was pulled over and taken to a detention center. She received none of the rights and privileges you would expect, including making a phone call. The clinic staff had to track her down when she did not return from an appointment, and the only good part about that was they knew right where to look for her. Thus, farm workers are very reluctant to travel outside of known neighborhoods. Disabling conditions, such as a large hernia, provide the impetus to pursue surgery despite these obstacles. Services at our clinic are not provided free of charge, and patients expect to pay for surgery as well. But a sufficient amount of money must be saved. Patients want to know, how much will the surgery cost? This seemingly simple question presented one of our most significant barriers. For the most part, hospital financial departments and many doctors' offices cannot answer this question in a straightforward way. In the case of our hospital, patients may receive discounts, but the final cost is still not known ahead of time. In terms of other hospitals, we know of one hospital that would not even discuss discounting fees unless the patient could prove citizenship. Migrant farm workers with valid visas issued by our government due to a recognized need are never going to be citizens. If a hospital is willing to discuss discounts, they're often based on sliding scales that demand income history that is hard to obtain or varies dramatically from week to week. These bureaucratic hurdles alone can demand more time off of work. And since this process is applied on a case-by-case basis, it is cumbersome and unpredictable. Furthermore, and I think most importantly, most hospital executives do not identify the migrant and seasonal farm workers as their patients. The farm worker population is physically and culturally hidden. They live tucked away on farms in an almost parallel universe. You will never see them. One of the largest on-farm camps in our area, with 150 migrant employees, is 2 miles away from an upscale restaurant. The clientele enjoying their meal there have little appreciation that those harvesting the crops live and work on the farm just around the corner. Our goal was to develop a system that would enable predictable and affordable fee schedules which would allow patients to determine the feasibility of pursuing surgery. Since this population is young and healthy for the most part, and the incidence of surgery is low, I decided to kickstart this process by agreeing to provide surgery gratis. Although this helped, we still could not get anyone to schedule surgery because the major expense remained hospital charges, and these were also the most difficult to predict. After failing to obtain any across-the-board concessions from my hospital's financial services department, I eventually went to our CEO and leveraged my position as one of their long-standing medical staff members into an agreement. The hospital offered any Finger Lakes migrant health patient Medicaid rates. This memorandum of understanding instantly made predictable and affordable rates available for any procedure at a single phone call. Our anesthesia group followed suit about a year later. This program was slow to take hold. Much as Dr. Rodas mentioned, it took some time for patients to overcome the unwillingness to address their surgical needs for all the reasons already mentioned, but over time, word of mouth and increasing trust in me personally resulted in success, which then spawned its own problems. By the 5th year, we were seeing significantly, and I mean significantly, more patients than I had anticipated. Our hospital rates, and especially the ease of scheduling, were so much better than other hospitals that we began attracting patients from 75 to 100 miles away, with the intervening hospitals assuming little responsibility for those patients in their backyard. And the largest limitation was that I was approaching retirement, and the program was too dependent on me personally. As I was trying, admittedly with little success, and recruiting other surgeons, and then through them their hospitals, a young physician assistant employed by Finger Lakes Migrant Health had some surprising victories. Jessica runs a primary clinic 20 miles from the hospital I mentioned earlier that had refused discounting any services for patients who could not prove citizenship. At a community healthcare networking meeting, Jess explained the difficulty she was having getting healthcare for her patients at the hospital. Hospital personnel and attendants initially denied that there were any migrant workers in their service area. This, unfortunately, is probably an honest belief and just underscores the invisible nature of this population. That hospital I'm talking about is surrounded by farms that employ a huge number of migrant and seasonal workers. After convincing the hospital representative that there were, in fact, quite a few migrant and seasonal farm workers in their catchment area, and that they were not being offered discounts available to other community members, things began to change. Other attendees at the meeting insisted that the hospital look into the situation and report back. With pressure from these other healthcare providers, Jess convinced this community hospital to recognize the migrant and seasonal farm workers as members of their community. They now need only bring their pay stubs to enter the sliding scale process, and if you are curious, the average farm worker receives up to an 80% discount. Our redoubtable physician's assistant, Jessica, is a great recruiter, and between the two of us, we are slowly developing a cadre of interested surgeons. Hospital engagement will be more difficult and will require imaginative and individualized solutions. My conclusions: for months or years at a time, farm laborers, though never our next-door neighbors, are an integral and sorely neglected part of our communities. Healthcare is not just diarrheal diseases and vaccinations. Surgical care is often a vital necessity. Free care is not the goal. Predictable and affordable care should be. And lastly, surgeons, I think especially surgeons and other healthcare workers, can help to get your hospital on board to help solve this problem. If anyone has any interest in the topic, this single website is a great resource on the federally qualified healthcare plans that offer federal migrant programs, and I would encourage you to look to your neighborhoods and see if there's one in your site. Thanks very much.